So, hello and good evening. I'm Marlene Speth, and on behalf of the organizing committee and the ERS, we are happy to welcome you to the ERS webinar series with a great team of panelists. We would like to thank Olympus as the main sponsor. So this evening is really special because it will be the second holiday edition, and we would like to present interesting rhinology cases. It is a real pleasure this evening to welcome 5 colleagues from all over the world to share this session just before Christmas. We have Professor Alkis Psaltis from Australia. We got Gerold Besser from Austria, Jaime Artiles from Spain, Rennie from the UK, and Christian Wald from Austria. Especially in this webinar, we would like to encourage you to type questions into the chat and Q&A. So without further ado, I would now like to pass over to Alkis.
Thank you, Marlene. I'll just share my screen.
Yes.
I might need you, Marlene, to not share, to unshare yours. Oh, great, perfect.
Can you share yours now?
Brilliant. I can share mine. Thank you. So, look, thank you very much for giving me the opportunity. It's early in the morning here, but I'm excited to be involved in part of this webinar. So the case that I'll be presenting is this patient. She's a lady who presents with a 4-month history of clear left-sided rhinorrhea, salty in taste, and basically preventing her from lying down in bed at night. She had no significant other history other than some hypertension, some age-related urinary incontinence, and some low back pain. On endoscopy, when we went into the left side, we could see secretions and pulsations from the left sphenoid ostium. So it's very convincing, obviously, that we're probably dealing with a CSF leak. We tested her for beta-2 transferrin, which is a test that we have in Australia. It's an electrophoresis test that separates out the patient's secretions. And based on that, we can determine whether or not they have an extra band, which is obviously beta-2, and she was positive. I think it's really important to highlight 2 points here, is that beta-2 transferrin is stable in the nasal secretions for up to 7 days, so patients don't have to rush off and send it the day they take it. And also that there are reporting errors, and these can happen if the patient has other issues, if they've got allelic variants, or if it's contaminated fluid with saliva, or if you're doing a resection and involving the orbit as well. In terms of imaging, this is the CT scan of this patient. Can you see the slides, Marlene?
No, I can't see the slides, and I think the others also cannot. Just 1 second.
Just seeing yours, maybe, Marlene.
Okay, 1 second.
I'll stop my share.
I've also stopped mine. You should be able to share it.
Share now?
Yes, please.
1 second, mate. Share. I've lost it now. Can you see that, Marlene?
No, I can't.
Can you see it? It says my screen share is loading, which I've never had before.
Can you share now?
It's now stopped me from sharing.
So there are 2 share screens, and you have to choose in Zoom options between both. Maybe you have to close yours, Marlene, so it's only Professor Alkis the slides.
Yes. Can you share yours now?
Now I've lost my presentation.
Early in the morning in Australia, Alkis. We'll let you off.
Maybe the Macintoshes are going to sleep as well. I'll start again. I'll just reload. Okay, and I'll just try to reshare. Let me know if you can see this in a second. Can you see that?
Yes, perfect.
Great. I'll start again, Marlene.
Yes.
So that everyone can see the pictures. Okay, apologize for that if that was my fault. So this is the lady that we were talking about. She's an elderly lady who presents with a few months history of clear rhinorrhea from the left-hand side. This rhinorrhea was present every day. Whenever she leaned forward, she had a brisk leak of this fluid, and she couldn't lie down in bed at night because it basically pulled in her nasopharynx and prevented her from sleeping. She didn't really have too many other comorbidities, as we said before. On endoscopy, through the left side, we can see these secretions coming out of this sphenoid ostium, and we can see pulsations as well. We tested her for beta-2 transferrin, which was positive. And I suppose I just highlighted the fact that there are studies that show that beta-2 transferrin is fairly stable in the nasal secretions and can persist up to 7 days. And so obviously this has implications when we do skull-based repairs and the patients are tested very early on in that period, it will likely be positive. Or also if the patient lives remotely, they have a few days to get you the specimen. There are obviously also issues that we have to look at, and there was a recent paper in IFAR of this year which talked about reporting errors. So this is the patient's imaging, and what we can see, the salient feature is complete opacification of that left sphenoid sinus. And if we look carefully, we can see that around the Vidian canal and the foramen rotundum, we can actually see a small defect in the skull base. So right next to the foramen rotundum. And here we can see on the axial scan, in the bottom right-hand corner, in the lateral sphenoid wall is the location, in that greatly pneumatized sphenoid recess. An MRI confirms that there's not only fluid within the sinus, but there's also what appears to be some soft tissue in connection with the temporal lobe. So a little bit of extruded brain, a meningoencephalocele. So I just wanted to speak about intrathecal fluorescein because in this case, you don't need to localize the leak, but often you do in a spontaneous leak where you can't find the cause. It's off-label use. This is my dosing. I use 0.1 mils of 10%. I dilute it in 10 mils of the patient's CSF, and I inject it 10 minutes back into through the lumbar drain while the patient's awake. There is thought that it could be toxic at higher doses, but if you use it at very low doses, and the doses that I'm recommending here, it's not only effective, but there have been no reported side effects from the fluorescein itself. And we reviewed this about 10 years ago when I was on fellowship, and at these doses, it's a really safe way to do it. And this is just how we do it. I use an insulin syringe. If I'm doing it, I 0.1 of a mil. I then inject it into the patient's CSF fluid that I've drawn off slowly. And it's really important to then deliver it slowly and ask the patient if they have any neurological sequelae while you're doing that. Generally, I position the patient in Trendelenburg, so head down for about 30 minutes so that the fluorescein can diffuse into the cisterns. And this is what it looks like if you're using it. This is not this particular patient. This is another patient with a dehiscence in their roof of their right sphenoid. And you can see how the fluorescein really helps localize the source. And if you have a Woods lamp, which most of us don't, which is a blue filter, it really does predict or show the fluorescein better. So really quickly to review the anatomy for this patient, obviously we know that the sphenoid bone is really where the sphenoid sinus sits. We can see the structures, the foramina there. We can see the most inferior foramina to the medial aspect of the patient is going to be the Vidian canal. And then more laterally and superiorly is the foramen rotundum. And obviously, when a patient has a lateral recess leak, you have to approach it through a transpterygoid approach. and often have to sacrifice the Vidian nerve to do so, but not always. So this is the procedure for this patient. We did an access middle turbinectomy because we'll need to obviously get good access and go laterally. We then complete a left-sided fest procedure, and here you can see us performing an uncinate. And then we complete a complete total sphenoethmoidectomy. Once we've opened the maxillary sinus, sometimes we need to put a little rotational flap in there. We can then proceed quite quickly with the dissection of the ethmoid. And this can be done with a debrider. We then go into the sphenoid ostium, which is located medial to the middle turbinate. And using a rongeur, we make a wide sphenoidotomy, which you can see we're doing here. And here we can start to see the clear fluid already coming into view. In this particular case, I wasn't sure whether or not we could preserve the sphenopalatine artery, although I think we would likely be needing a sphenopalatine artery, a ligation to perform a transpterygoid approach. But I always try to preserve it if I can, because if I can use a flap on this side, we'll pedicle it onto the sphenopalatine artery. And here you can see us raising it off the vomer and the posterior wall of the nasal cavity. And then we proceed to drilling the floor of the sphenoid right down to the rostrum of the sphenoid right down to the floor. Now, you can see at this stage that with the 30-degree scope, we can visualize the meningoencephalocele, but we really can't access it with instruments. And we're going to need to reduce the meningoencephalocele and then obviously close the skull base defect. And so this is why we need to perform a transpterygoid approach. And in this particular case, even though we've spent all that time preserving that nasoseptal flap, we have to sacrifice it. And the first part will be to cauterize the sphenopalatine artery. We can then drill out the Vidian canal. The patient has been consented that they may get some sort of dry eye, up to 30% of patients will, by sacrificing the Vidian. And at this particular time, I'm now removing the sphenoid sinus mucosa to access the lateral recess of the sinus and the meningoencephalocele. And we remove this because if we do put a little flap down, we don't want to get a mucocele. So here we can see the carotid artery bulge. We're using a 45-degree bipolar, and we're attempting to cauterize the meningoencephalocele. And you can see that we are managing to reduce it somewhat, but there's still quite a large volume of that meningoencephalocele, which we're going to need to close. So we're going to do a transeptal approach. We're going to do a posterior limited septectomy. On this side, we're doing the same thing that we did on the ipsilateral side. We're going to be using this mini rotational flap in at the end of the procedure. And we use this flap so that we can cover the exposed bone, and the patient will get much better and much faster healing with less crusting. So here we're doing a transeptal approach. We're creating a small septectomy, removing the bone of the septum, and then we're going transeptally to access the meningoencephalocele. We realize that we need more access, and so we will extend our transpterygoid approach out by drilling on that pterygoid process. And at this stage, we can now get to the entire part of that meningoencephalocele and reduce it right down. Once the meningoencephalocele has been reduced, or here you can see that we're still not happy with the access, so now we're drilling on that palatine bone just so that we can angle our instrument right up into that lateral recess. And here you can see reducing that meningoencephalocele further. And we'll do that until we see the skull base defect. And then we use fat, and I harvest the fat from the ear in this particular case. I like to use earlobe fat because it's more fibrously held together than abdomen fat. The patient will always ask you can take some off my abdomen, but this is the approach. Now, this is a very important needle to do. We make a knot in one end, and then we pass the needle down the same end of the knot in a longitudinal fashion. And this will allow you that when you pull on that stitch, for the fat to concertina like a accordion. So when it's intracranially, it will fill in the skull base defect. So here you can see we can see the defect has been reduced. We can see Vidian canal, the foramen rotundum, and the optic nerve sitting above us. And here we are now inserting the fat in just below the foramen rotundum. And this is a very tedious process. It takes time, it takes patience, because you're trying to insert a much bigger piece of fat into a very small hole. Once we do it, and once you get about 50% in, the fat will completely be lost out of view, and you can then pull it. And the aim is to try to pull the fat so that some of the fat sits intracranially and puts pressure on the skull base through the brain pulsations. We've now raised our mini nasoseptal flap from the patient's right. It says left there, but it's right. And here you can see we're now covering the exposed bone. And this is the 4-week post-operative view. We can see that we've got a good view of the repair, and it's already mucosalized, and she stopped leaking. So thank you very much.
So thank you very much, Alkis, for this interesting case. Just because you have to, I think you have to run off to clinics. You're starting your day in Australia.
About half an hour, yeah.
Just we have 2 questions in the chat. Could you? So someone is asking why you didn't start with the transnasal sphenoidotomy, and another question is what is the concept behind the blue filler and how it is used?
Around the blue filler?
Filler and the usage.
Oh, the blue filter. Yes. So so I don't do the transnasal because this patient's going to need wide access. You can, if you wanted to do a transnasal and do the approach that you do for a pituitary, but I'm going to need instruments that are going to lever on the lateral nasal wall. You could see with this large recess that even after I'd performed an ethmoidectomy, I then had to drill more of the palatine bone and the pterygoid process to get my instruments out there. If you have a sphenoid leak, which is in the central or medial portion, you can do a transnasal sphenoidotomy and simply do it by that approach, which is what we do when we access the skull base. But for those lateral recess ones, you need that extra room. And the only way that you achieve that is by performing your ethmoidectomy and then drilling down the pterygoid root. In answer to your second question about the blue light, it's obviously it changes the color of blood compared to fluorescein. It's a filter, a UV filter. And the concept of the Woods lamp is that you remove the blood, which and the red color saturates obviously light, and it then allows the fluorescein, which will become which won't get altered by the blue light, to shine brighter. The reality is most people don't have blue lights in their hospitals, and certainly whenever I've looked for one, I couldn't find one, and that was from someone else's textbook, that picture of the blue light.
But it works also without.
Wood lamp, yes.
Yeah, I mean you will also see the fluorescein to a certain extent without the filter.
Oh yes, yeah, you don't need it. The problem is sometimes with these very low flow leaks, you may not see the fluorescein. That happens occasionally, but generally with a larger volume, you will.
Okay, thank you very much. Thank you very much for joining us tonight or this morning. We would now like to go on to one of our next speakers, and I would now like to pass it to Gerold from Austria.
Can you see my screen now? Can you see the slides?
Yes.
Yeah, okay. Hang on a second. Okay, back and forth. Do you hear me? Yes. Okay, perfect. Thanks very much for the invitation. I'm happy to be on this panel and on this special cases ERS webinar. I have much less complicated cases, but still I think they are nice to see. And it's actually 2 pediatric nose cases with some similarities. And the first one was a girl, 9-year-old. She was a bit tough to handle. The examination was challenging, and she visited other ENTs prior to the visit in my office. And she complained about nasal congestion since 3 to 4 months, no rhinorrhea, no effect of nasal rinsing. And she snored a lot, as far as her mother told me. And there was a possibly reduced sense of smell, according to the mother. And also teeth needed to be extracted, but she wouldn't let do anything about of that. So the examination in the first place must have been quite hard for other ENTs, but I managed to take a quick look, and I saw this polyp on one side, and it was quite obstructing the whole nasal cavity. So I also did some sniff and sticks test, and she actually was able to identify quite a lot of these smells. So the other side must have been free. And as you can imagine, I put her on a CT scan, and the diagnosis, I think you already know it, was an enterocorneal polyp. But I think also what is quite interesting, and I don't see that every day. I think I'm pretty sure a lot of ENT surgeons on this webinar have already seen it. But I think the sagittal view was quite impressive with the enterocorneal polyp going this far down. And maybe if we would have waited another 1 or 2 months, you probably were going to be able to see it from the mouth already. But in this case, I wasn't able to see it from the mouth side, but it reached all the way to the back of the uvula. So what we did was we performed, obviously, surgery, which is the treatment you do. And once I grabbed this polyp with the forceps, a lot of fluid came out of it, and the size decreased massively. And as you can see on the histology finding here, or on the what I got out of the patient wasn't that big, but still it was hard for me to get it out of the nose. So I managed to get out the polyp through the mouth. So this is obviously quite a one-look diagnosis. It's easy to diagnose if the patient lets you do a CT scan or lets you do a endoscopy. The next case was a bit different. Although this boy turning 7 was very brave, he actually let you exam a lot. He visited other ENT specialists prior to the visit, but even though he was very brave and he could perform a nasal endoscopy, the infrared turbinate was so swollen you were hardly able to see anything. So I performed endoscopy after decongestion, and I was able to see at least a little bit of a polyp on one side again. But the nasal congestion only was for 2 months following a tonsillitis, and snoring only for 2 months. So quite impressive how short-term these complaints were. And now I have the CT scan. Yeah, now it comes. So I was quite amazed how the septum was already a little bit going to the other side with a spur there, and also the ethmoid and also the contralateral side was full of mucus. So I wasn't quite sure about the diagnosis of an enterocorneal polyp at this point when seeing the CT scan. So I did allergy testing, and I recommended a sweat test. Until now, they haven't performed it yet because they weren't able to organize it. But still, in Austria, we have a screening test right after birth. So cystic fibrosis, the chances for cystic fibrosis are quite low, but still, to be sure, I wanted to do a sweat test they did a pulmonary checkup at least, and there was a normal pulmonary function. I put him on rinsing, I put him on topical corticosteroids and also oral corticosteroids, and I followed up in him once, and there was a clear improvement. So we waited a little bit, and after a while, we decided to go for surgery. And during the surgery, it looked again like quite an obvious disease, even though the CT scan prior to that almost looked like a bilateral disease. So at this point, I was quite sure, okay, it's an intracoronal polyp, we do surgery and everything is going to be fine. And during the surgery, it looked all good. I had a 70-degree angle endoscope to look all around the corner to clean all the sinus maxillaries. And in the end, the polyp size wasn't that big, but everything looked wide open. And I put in some sinus foam. As you all may know, the Stamberger foam. And I followed him up once and they were quite happy. But then they showed up 6 months afterwards, and I was quite impressed to find a polyp with this sort of odd look again in the same patient. So I was kind of afraid this turned into an inverted papilloma or was something else. And also the septal spur on the left side was quite narrow, probably even a bit more than in the previous examinations. This was 6 months post-op. So I did another CT scan, but it was clearly the right side. Again, on this CT scan, I discussed with some colleagues, and I had a friend of mine over, as an ENT surgeon, and we performed another endoscopic sinus surgery, and we didn't do a pre-lacrimal duct approach. We didn't do a fossa canina approach. We just did the same surgery again with a larger antrostomy, looking all around the corner, cleaning everything up again. And the interesting part about this was that initially when removing the polyp, unfortunately I don't have a video, and the pictures are quite bad, but still you can imagine a little bit of it. Here the ostium looks quite large. The bone, you can already see the bone, and I think we reached the attachment. But what was odd 6 months after the first surgery was that I still was able to find some parts of the initially put in foam. So this hasn't, for some reason, hasn't resolved totally, which was quite of interesting, and so that we decided to not put in sinus foam at the second surgery, just leave it open. We installed some glucocorticosteroid into the sinus maxillaris, and we didn't put in foam. And we did an extensive working to clean it all up, but no Villach or fossa canina approach. And I think, especially in this case, if you look at the coronal plane again, you can see the teeth down there just being in a waiting position. And I'm curious about the discussion which is coming up, and we will see if somebody else would try for a fossa canina approach with these teeth in the way. But I think in this case, it was safer to just go for endoscopic sinus surgery. I saw him now a couple of times afterwards, and unfortunately he developed this synechiae on this side, but there's no sign of polyp. He did a lot of corticosteroid rinsing, and I wonder if this case is going to keep me busy for several other years. And I wonder if anybody in this webinar will answer me the question at what age a septoplasty would be a good option in this patient, because the left side is quite narrow, and I think at some stage he will benefit from a septoplasty. So I looked up the literature, and as a conclusion, intracoronal polyps are common. I'm pretty sure most of you have seen one. The recurrence rate is fairly low. If you do a combined approach, apparently it's even lower to close to 0. But it also brings some risk, especially for the teeth region. And there is one study with just 20 cases, but still 2 cases showed an inverted papilloma after removal. But one of these patients, I looked it up, was 64 years old. So in a pediatric population, these chances are probably even lower. But still, you have to think about it. And as you saw this picture where the polyp sort of had a reddish color, I was curious if it hasn't turned into something like that. But it hasn't. The histology didn't say something like that. There's another review in Rhinology. They say pretty much the same. Called Villach procedure is associated with damage, and it can be added to endoscopy. And what I find quite interesting is they did some enhanced expression workup, and there are some interleukin 6 findings in comparison to controls. And so in recurrent cases, this might be an option in future to save some time until the teeth are not in the way, and you can perform a proper approach from also from the front, like a pre-lacrimal approach or a fossa canina approach. So I'm ready for a discussion.
So thank you very much for the great talk. Do you have any questions yet? Otherwise, I'll start with some of the questions from the chat. So we've been asked whether you've done a wide maxillary antrostomy to address the site of...
Yeah, for sure. We went all the way anterior to the lacrimal duct.
Okay. And then...
What was the dosage? That's a good question. I have to look it up. That was like 2 years ago.
Okay.
Can't quite remember. It was the pediatrician prescribed it, as far as I remember.
And when you were talking about rinsing with steroids, what exactly did you mean by it?
I put him on budesonide rinsing. So you pulmicort, like what you use for asthma inhalation, you just put into the nasal rinsing, salt water nasal rinsing, and you put it in there once a day.
Mm-hmm. Okay. Thank you. And then we have another question about the possibility of eGPA. What do you think?
eGPA? What do you mean by it?
Beginners. So vasculitis.
Vascularitis?
Vasculitis.
Vasculitis. I don't know. It hasn't shown up. Would it show up in the histology?
eGPA is normally adults rather than children. You usually diagnose as an adult.
Mm-hmm.
Eosinophilic granulomatosis with polyangiitis.
And you will not really see it in kids pretty much never. And also it will have typical signs like a very angry red lining on both sides, not just one side. There'll be a lot of crusting, and so it looks different.
Yeah, okay.
Okay, I think those are all questions for now. Or amongst the others, do you have any questions to Gerold? Otherwise,
or wise remarks,
or ideas?
What age would you do a septoplasty then? When do you do it? I don't do children, so I can't comment. I'm only adults, but I'd be interested amongst the group.
That's the big question I have for you guys. I'm not sure. I think I've done a septoplasty in a 13 years old. So that's could be a good age, I think. We can't hear you.
I think there's really good evidence to show that obviously nasal obstruction can lead to problems with midfacial growth as well. So I have no hesitation. If a patient's got a septum right off to the one side and they can't breathe through their nose and they've got a polyp on the other, I would do it in as young as a 6-year-old.
Oh, really?
I warned them about the theoretical risk of affecting nasal growth, but that was all on porcine studies. And I don't think the evidence is really supported in humans. And these kids are going to get problems with their nasal growth anyway from not breathing through their nose. So for this case, you need a diagnosis. I would do a septoplasty. I would be as conservative as I can, but you need a thoraxis.
Mm-hmm. Thanks.
Okay, thank you so much for your great case, and thank you all for the questions. We would now like to pass over to Jaime Artiles. He's practicing in Spain and originally from the Canary Islands. We are happy to have you here.
Sorry, just on call, and in this right moment they call me, but nothing.
Otherwise, we can.
No, it's okay. Yes, my resident, she can manage it, I'm sure. Okay. First of all, thank you so much for the invitation. It's a pleasure to be back here with the European Rhinology Society in such a nice time. I'm very happy to share this because it's an unfinished case. It's a case that is being giving me headaches for many years now. And when Marlene asked me if I had interesting cases, I said, yes, I want to show this, and maybe some doctors smarter than me will help me with it. So I'm going to talk about classical mucocele case, but that it turned not as good as I expected. So in the first consultation, it was in 2017. So it just a couple of months after I started my new job after fellowship. So I was new there. I had to show that I could do things by myself, and this mucocele came to me. I was very happy. 78-year-old, very nice woman. She's been with parapupillar edema and orbital pain for longer than a year. But no one was taking her seriously until she came to the ER, and ophthalmologist saw her, just ordered a CT scan, and this was her CT scan. So she had a classical mucocele with some orbital extension, some bone erosion, and when they saw this, they sent the case to me. So I said, okay, this looks like a very good case for endoscopic approach, and that's what I offered the patient. And I think it was going to be a big challenge because it was getting almost in the orbital midline, but it was going to be good. So I did classical endoscopic sinus surgery, ethmoidectomy, frontal sinusotomy, draft 2A. And I drained the mucocele, just leave it open, and I was so happy. After the surgery, the patient just recovered. She stopped having some diplopia and orbital pain. So clinically, she recovered. I thought that was going to be it, but it was just the beginning of this horrible case that I used to call this patient, not this patient because she's very nice, but this case, my nemesis. And I think now this is a Christmas theme talk, so I'm going to call her sinuses the Grinch. So I'm going to explain you why I'm saying that. This is her third post-op video. It was at the beginning of 2018, and as you can see, you have some neosteogenesis. The frontal recess is not looking good. I cannot really see inside her frontal sinus, and during the surgery, I drained the frontal and the mucocele, but it was scar closing. So I was not happy with this result. She had a very nice clinical recovery at the beginning, but following some time, sometime after, she started having again mild diplopia, just looking in the lateral gaze, and she had a flu, and after that, a lot of periorbitary edema, orbital pain again. So basically, signs that the mucocele was back. And as I couldn't see inside of her frontal sinus, I said, okay, I have to do a CT scan, and I have probably to do another surgery. That's what I did. I told her that we need to do it again. So we did it. This is the new CT and the second surgery. This time I was a bit more aggressive, and I did draft 2B open wider. As you can see here, I can find again the mucocele, open it again, just drain it, and I tried to remove the all this capsule, but it was not possible. So I tried to marsupialize it and leave it as wide open as I could. So as you can see, the marsupialization and the end result, this is the final part of the surgery. You can see it's fairly wide open, and I was happy after this second surgery. However, she didn't recover her diplopia as well as the first surgery. So maybe there's some damage in the orbital muscles by that time, but I thought that with this procedure she will recover better. However, it didn't work. As I said before, this is my Grinch sinuses, and she's scar closed completely. I don't have pictures of this part, but I talked with her and I asked her, I think we should do another surgery. Now I'm going to do the biggest surgery I can, which is draft 3, make it as wide as I can, and let's hope it worked this time. So I did the draft 3, and you can see the timeline below. So now we are at the end of 2020, right? And after the draft 3, this is 3 months after this third, no, 1 month after the third surgery. I did this first in UCT, confirmed that the mucocele was back, did the surgery. As you can see here, I left some silastic in the front, in the draft 3, just to prevent this scarring. But as you, it's starting to close again, right? I was very happy at the end of the surgery, fairly wide draft 3 frontal sinusotomy, but now it's starting to close. This was 1 month. So 4 months after the surgery, she came back and she looked like this, completely scar closed. She even scarred over the silastic. So this is at the office. I had to remove all this scar tissue, try to find the silastic stent, try to put it out, and then I just place it again, because if I remove it completely, I was sure it was gonna close totally again, right? So now this is 4 months after the third surgery, which is a draft 3, right? So 9 months, Grinch come back again. I have this final shape with the shape of the silastic, but you cannot see in the left frontal sinus. You only can see the right frontal sinus, but the left frontal sinus is completely blocked. It's completely a scar closed, right? So at this point, I had a conversation with her. She's still having some diplopia and some symptoms. And I told her, okay, now we have 2 options. We can do it again endoscopically, and I will try to make it even wider and use some mucosal graft that I was reviewing the literature by the time, or we can go externally. We can do the black stiff flap and obliteration of the sinus. So she decided, try it again endoscopically, even though by that time she was like 82 years old, but she preferred the endoscopic approach. So we did it again. And this is the 4th surgery. This is the beginning of the surgery. You can see very narrow. This is after 3 surgeries. So I opened it again. This last time, the surgery was much more difficult. A lot of knee osteogenesis. Drilling was very, I had to drill so much. This is looking, I'm looking at, I do the frontals with a 70-degree scope. That is why you're seeing this fairly nice. But the mucocele was very lateral this time. I managed to find it, I managed to drain it, and I managed to open it, but not very much. So I say it's going to close, I have to put something there. And I put this silicone tube, and in order to keep it in place and to prevent scarring, what I did this time was to use some free mucosal graft from the nasal floor. As you can see here, it looks fairly nice and open, right? So I wasn't very confident that this tube was gonna stay there much, but as you can see here, 1 month after, it remained there. It looked kind of open, the draft tree. The tube lasted like for 2 months or something like that. I wasn't very happy, but I was a bit desperate by that time. And this is how she looked 4 months after the 4th surgery. As you can see, the only space that I have there is where the tube was. And but she's been doing not bad clinically. This is her last CT scan. You can see mucocele still there. You can see the osteogenesis. However, there's not orbital compression this time, so there is no diplopia due to mass effect, only to the rectus inflammation, right? This is 3D reconstruction. So this is how she's doing now. The surgery was at the beginning of the year. I've been seeing her since, and she's doing quite well. Her diplopia is only in the lateral gaze, but she can do normal life, looking, reading and walking, no problem. She hasn't had new infections, edema, orbital pain. But as you can see, I haven't cured her. She still have this mucus there, which it could make her have some troubles in the future. So soon, some months after this last surgery, I had the chance to use a steroid eluting sinus stent. This was in September of this year, which looks kind of promising, but I don't have much experience using them. I remember that when I had this case, I really wanted to use these implants with this patient, but the company that provided them told me that it wasn't approved in Spain yet. So I had to wait, but the patient couldn't. So we did the surgery without the steroid stents. So my question is, why in another case very similar to this one, you do a draft 3 with a mucocele, you end up with very nice wide open frontal sinuses, and in this case, you have a patient that scars down so aggressively. My question is for everyone: what should I do next? Wait and see. New surgery with the steroid eluting stents, sinus trephination when it's needed, osteoplasty flap, or send it to another doctor? Do you spot any mistakes? What have you done differently? How can we predict or even prevent this scarring? And should we treat mucoceles more aggressively? I had this another mucocele this Tuesday, so I went very wide just in case this story repeats again. Thank you very much.
Thank you so much for your talk and the interesting case. There's already Pavel with a question, I think, or an idea.
Thank you maybe. For this talk is really interesting, and I'm sure that all of us now and then have cases like this. The first question, why it is happening in one patient, not in the other? I think it does have something with a TH type of disease. So I think this is more like a TH1 type of disease, where there is osteitis, inflammation of the bone, chronic infection, rather than eosinophilic infiltration. I would guess that this patient didn't have necessarily asthma or aspirin intolerance.
No.
In those patients, the polyp, they just simply keep it open, and in patients who do not have these two diseases, additionally, it tends to more be associated with the biofilms. I had actually literally copy-paste case last year, and eventually what I ended up, I did the blepharoplasty approach, and because it was shallow, I literally drilled down the whole floor of the frontal sinus, and I let the orbit contents to collapse in it, because it was shallow-ish. So and removed all the mucosa inside, and literally just the frontal sinus disappeared. So like cranialization, but from the other side, from the orbital side. And I think that is very often the option in these kind of cases. The problem is if the wall is missing, and you essentially end up with the mucosa on the soft tissue contents of the orbita, right? So how are you going to make sure that all the mucosa is gone from? How are you going to stripe it off? Because it's easy to get it off from the bone, but it's more difficult to get it from the orbital contents. Yeah, but I think the cranialization and obliteration in the end, very often in these cases, is one of the ways. The stent, I tried, it failed. I did a proper, but I'm certain that the occupation is different. Maybe I did it wrongly, I don't know, but it just didn't work.
Okay, but it's nice to know that you tried Propel and it did work, because I've been always thinking about that option.
But Alkis has got a raised hand, and I'm certain that in his case it would be maybe something more interesting.
We can't hear you.
Technology is early in the morning. I've had the exact same case, Jaime, and thank you for presenting it. I think it shows courage, but it also shows what a good doctor you are to present it. I had the same case 10 years ago, and then I did the same operation on a new patient with the exact same pathology on Monday. And my approach was completely different for both, because I learned from the first one. The first thing I think is that mucosils are different to sinus disease. And for a mucocil in the frontal sinus, especially when there's dehiscence of the lateral wall or the orbit or the skull base, I always do a drill out as my first procedure, because they close down for some reason, and I don't know why. And I remember when I came back from fellowship in 2012, I had the similar case to you. I did a standard approach. I was very proud of the AP diameter. And then PJ Wormald, who was in the office next to me, said, "Why didn't you do a drill out?" And I said, "Why would I need to?" And he says, "You watch, it will close down." And he was 100% right. So the first thing, I think I do a drill out, because the first time you do a drill out or a modified Lothrop is the best time, where the tissues are virgin, you don't have scar tissue. The second point I would make was there was a lot of crusting in that cavity at all time points. And did you treat the patient at all with topical antibiotics in the early post-operative period or not?
Not usually. I usually use steroid rinses, steroid eluted rinses, but not antibiotic in this kind of cases. You think it will help?
So yes, 100%. So a lot of staph in the nose causes neosteogenesis and causes the crusps. And the crust essentially is what encourages the adhesion formation and the neosteogenesis. So I would have a very low threshold to be very aggressive with my debridements in the first post-operative periods. I'll debride them every week, so I don't have any crust sitting there, and I'll put them on topical mupirocin, if it's Staphylococcus, for a month. And that significantly improves my post-operative healing. And once you get nice mucosalization, the bone's no longer exposed, there's much less risk of it closing up. I know that the evidence-based criteria that we see in IFAR every year say there's no evidence, but anecdotally for these patients, the only way that you can treat a biofilm is by using a much higher concentration of antibiotic than oral, and that's by topical antibiotics. So I use, my dosing is a concentration of 0.05% or 10% of mupirocin gel, and I put 1 ml of that in 200 ml of flow. So Pavel, you have a question?
Yeah,
or statement?
Yeah, antibiotics, absolutely. I forgot about that. So I clarithromycin long-term, and then also the local. So we started with xylitol and saline, But now I swapped to betadine, saline, and ciprofloxacin drops. We do it for cystic fibrosis patients. And actually, recently I started to use what is the name? Optiloop, because it contains the glycerol. It's gel, it's a water soluble, but it contains 20% glycerol. And so it's a very similar mode of action as a xylitol. And that actually I use after draft 3 and after exposure of the bone and in also disease like this. And it seems to be working quite well.
Yeah, definitely, because I think it reduces the bacterial load. The other thing that I would say I do now is I rotate random flaps to cover the bone, because the free mucosal grafts that we use die off. They're essentially a biological dressing, and they're good for certain parts. But if you can use either a lateral nasal wall, flap, or you can rotate it in from the other side, the healing's much better. But this is a difficult case, and once it's in the bone, it's very hard to treat these infections.
Very nice. Thank you for your comments. I think it's very useful for the future cases that I'm sure will happen.
Yeah, we all get them.
I'm not alone.
So thank you all for the great discussion and for the case. We would now like to hand over to Catherine from London. We are happy that you're here with us, please go ahead with your talk.
Great, thanks. I'll just try and share my screen. Bear with me 1 second. So hopefully you can all see my screen now. Great. So I'm talking again about a difficult case I've had to deal with over the last 5 to 7 years. It's Christmas time. Everybody has colds, infections, and viruses. And this was one of the patients I had with a nasty infection that kept coming back to see me for a long period of time. So I'd be interested in other people's thoughts on it. So the patient's a 50-year-old primary school teacher. She's got chronic rhinosinusitis without nasal polyps. She was referred to our tertiary centre with ongoing sinus symptoms. She'd had full medical management, including macrolide antibiotics, intranasal corticosteroids, douching, and she'd had endoscopic sinus surgery done in her local hospital. However, in spite of this, she still had really foul-smelling nasal discharge, was requiring at least 4 courses of antibiotics every year, and ongoing symptoms of pain and pressure in her sinuses. And as she was a primary school teacher, it was getting to the point where the children didn't like being in class with her and were telling her that she smelt. So the patient was finding it awful to deal with. We diagnose our difficult to treat rhinosinusitis as those who've had adequate surgery, they've had good medical treatment, but they're still failing to improve in spite of this. Being a surgeon, I wanted to see if she'd had adequate surgery. Could I do any better? And how would I get on with this? So this was her CT scan when I first saw her in 2017. So there's been some reasonable surgery. There's a large antrostomy on the right side, but there's still some cells left in those sinuses. You know, there was something I could still do, I felt, to open it further and hopefully prevent any of this infection. The left antrostomy looks like it's occluded on that scan, and there are still some ethmoidal cells. So I thought I'd go ahead and do the surgery. All-girl team at Charing Cross, we were going to win with this case, but sadly it didn't work out that way. Intraoperatively, there was pus in the nasal cavity. We sent swabs for MCNS. The inflammatory tissue was throughout, so we took some biopsies at the same time. I widened the middle meatal antrostomies and completed the anterior and posterior ethmoidectomy. However, post-operatively, ongoing foul-smelling discharge in spite of having antibiotics. The histopathology just came back with chronic sinusitis, and the microbiology grew strep and mixed anaerobes, which was meant to be sensitive to the antibiotics that we treated her with. So where do we go next, and what do we keep doing for her? Well, she had lots of different courses of antibiotics from her primary care practitioner and from some of the other ENTs over the course of the next year. This is a list of the different bacteria over that time frame that she's grown in her nose. We've obviously discussed a case with our microbiologist to ensure we were covering it adequately. She's had a number of courses of antibiotics. You can see here, she's had prophylactic doses, she's had metronidazole, and she's even had gentamicin douches and topical antibiotics, as well as douching with baby shampoo, xylitol, hydrogen peroxide, and manuka honey. This was her scan now in 2019. So 2017 was before I operated, 2019 after I operated. Maybe I've removed some cells and opened the antrum a bit bigger, but she's still got disease there, and I haven't really improved that. Her snot score remains really high at over 80 in spite of having treatment. And she went on to have another washout of her sinuses with linezolid at the recommendation of our microbiologists. So the question was, is this really chronic rhinosinusitis, or is there something else going on? And what else should we be looking at? And I guess for all the trainees who are out, we need to be thinking about what other tests we should consider. So has she had the full allergy workup, all the microbiology? Have we thought about the mucociliary function? And then looking at all her blood workup, particularly immunoglobulins in somebody with hard to treat infection, but could it be an underlying vasculitis, or checking her vitamin D levels and things like that as well. Her ongoing microbiology continued to grow lots of different bacteria. She had E. coli, staph, and streps at various points in time. And we did the immunoglobulins for her. And as well as testing her immunoglobulins, which were normal, we do functional antibody responses. We run a joint nose clinic with the Royal Brompton Hospital, where they have immunologists. And they've taught me to check the pneumococcal antibody level and tetanus antibody level in these patients. And if the pneumococcal antibody level is low, we then immunize the patient and see if they have a response to it. This patient didn't have a response. So at this point, I'm sharing my pain with this patient and getting my colleagues involved. On the left here is my microbiologist, Dr. Sanderson, and on the right, my immunologist, Dr. Peter Kelleher. And they've both been fantastic in helping me manage these tricky and difficult patients. She's diagnosed with chronic rhinosinusitis without nasal polyps and now has a specific antibody deficiency with reduced memory B cells. Well, this is taking me back to medical school and beyond what I normally do as a regular rhinologist. But she then started on immunoglobulin therapy. Unfortunately, during the course of her immunoglobulin therapy, she developed 3 different abscesses at the injection sites and required 3 admissions for IV antibiotics to the hospital. COVID interrupted her treatment, and you can see she was starting on outpatient antibiotic treatment whilst she was on the immunoglobulin therapy. And you can see the different courses that she's been having here. COVID happened between 2020, August, and October 2021. And actually, that was her longest disease-free interval in the time that I'd known her. She had nearly 18 months without an infection at that point in time. So just a bit of the background on specific antibody deficiency. 5 to 10% of the patients in tertiary ENT clinics, and we look at their diminished antibody response to vaccination. Often just using the meticulous nasal hygiene will work for these patients with preventative antibiotics. Some respond to sinus surgery, and a small proportion require immunoglobulin treatment. And we train them, they give their own injections at home. But because they have this specific antibody deficiency, they're much more likely to get infections with pneumococcus, Haemophilus, and Marexella. This was one of the papers about recalcitrant chronic sinusitis, and it says up to 50% of these cases are found to have an immunodeficiency, and something that we should always be careful at looking at in our patients we're seeing with chronic rhinosinusitis that's not improving in spite adequate management. So with this patient, what next? She's still having foul-smelling nasal discharge. She's still on immunotherapy. And where did I go with her, and what should I do? One thing to note is she's a preschool teacher, and like many professionals who work with small children, they do pick up a lot of infections. As any parents on here will know, when their children are in nursery or preschool, they go down with coughs and colds far more frequently than they would normally. But it's a bit radical telling your patient to change their job. However, that's what she eventually did. And she's now working with learning disabled older children and adults. And I'm pleased to say that in the last 2 years, she hasn't had another infection. And at her last follow-up, it's the longest period she's been infection-free. So for Christmas, a happy story so far, but let's hope it stays that way. Any questions?
Thank you very much for the great talk. Really interesting case with a long story. Do you have any questions or anything from our colleagues? Paul, I see.
I just want to say it was really interesting and completely different what we normally would present and also expect. Yes, this is thinking out of the box. I think in my case, I would probably stop it somewhere in the middle. But having all these people around you, and also, yeah, it makes sense. And I think also it's important this makes us think about our patients differently. That is not just scalpel and endoscope. Thank you. That was really good.
Thanks. I tried the surgery first. Alkis, go for it. I can't hear you.
I'm hopeless today. Thanks, Kat. Great presentation. I've routinely sent off for these patients IgG subclasses, and the immunologists always come back, and even when they're low, tell me that it's a waste of tests. It's not specific, and the dynamic titers, which is what you said with the pneumococcal vaccine, is what they're interested in. I'd like the interest, obviously, of you and the other panelists. Given that the immunologists, at least in Adelaide, keep telling me that I'm wasting resources by ordering these IgG subclasses, I use it as a screening test to prompt me for further testing. But do you all routinely do that as part of your immune workup, or do you have the similar philosophy from your immunologists?
I definitely also get the immunoglobulin subclasses, and I don't necessarily always get the specific antibody response initially. I think it's a more expensive test, so I will check the immune classes first, because we do have the occasional IgA deficiency and things like that, rather than a specific antibody problem, which we might pick up there. If that's still negative, then they go on and have the specific antibody. But in the joint clinic at the Royal Brompton, where we tend to have patients who are much sicker and we have an immunologist in that clinic or attached to it, then they do get more regular testing there. But in my routine Charing Cross Hospital, I wouldn't get them straight away. They have to earn it almost, unfortunately.
Do you get resistance from the immunologists about IgG subclasses or not? No.
Okay. Great. Thank you so much for presenting this interesting case. Now, the last presenter is Christian Walch. He's a professor and the director of the clinic in Graz, of the Clinic Barmherzige Brüder. And we're happy to have him here with us. Christian, it would be great if
Malina, I'm trying to move on.
Yes,
Can you
perfect.
Yeah?
Yeah, we can see your slides.
Okay, you can't see me because my webcam doesn't work today. You have to imagine me being very beautiful, wearing my Santa hat, but still, okay, no webcam. I have a very simple case. It's just a fibrous dysplasia of the left frontal sinus. Fibrous dysplasias are rare diseases of the paranasal sinuses. It's been just the one we couldn't solve endoscopically this year. So it's some kind of interesting. The fibrous dysplasia is some like a scar-like tissue replacing the healthy bone. And you all know the histological outcome. The fibrous dysplasia usually in the paranasal sinuses leads to obstruction, to recurrent infections, to nasal airway obstruction. And if you have foraminal obstruction with facial pain or blindness, and you see some bony deformities. In our patient, she was 27-year-old female. She had some kind of head pain, and the neurologist took her to an MRI scan. And here you already have the diagnosis. You see some formations in the left frontal sinus, and you see also that the orbit is the left orbit is some kind of deformed now. So she came to my hospital. We performed another CT scan to plan the procedure. You see the frontal sinus is filled up with this bony mass, and the pain was not solved by medication. So we just tried, we just concluded that surgery would be the only thing. But you have to always to check if there is a bony coverage of the wall of the frontal skull base, and you see the original bone is very thin in this case, so you have to be very carefully performing this procedure not to cause a CSF leak. Also in the axial planes, you see that the masses are just destroying the natural bone. So we just performed an opening from the outside, the typical approach. Then we took our piezo saw to get through the bone and to have a very nice bone to replace. That was the plan. Then you see on the left picture that you couldn't get out the bone in one piece because it was adherent to the mass inside. So we had to make some portions of the bone. And then, as I'm an ear surgeon, I took the drill, first the round cutting burr, and then the diamond drill. And then you had we just drilled out the frontal sinus. In respect not to open the orbit, neither to injure the dura, we were very carefully. And when you remove this fibrous dysplasia, sometimes you can remark where is the natural bone and where is the dysplasia, because it has some kind of a different color. The dysplasia is a little reddish and the normal bone is some kind of white. So after drilling out the whole sinus, we just closed it again, and hopefully the patient will be better for some years. We have not done a control CT now because this surgery was performed just 3 weeks ago. So we have to think about the differential diagnosis. There can be sarcoma looking like this, or other malignant osteoblastic lesions, ossifying fibroma or Paget's disease, or something else like this. When you think about the therapeutic options, when the problem is very small, you can wait or scan and see. You can think about some radical excision, but this would mean exenteration of the orbit. Or you could do the conservative excision like we did, and we hope that it will help the patient. So this was my very short presentation. I wish you all a Merry Christmas.
Thank you very much, Christian, for presenting us this case. Interesting case to finish off. Do you have any questions also among the other panelists? Or would you have done it differently, or?
We've had a similar case, but the patient was very against surgery. So we've actually conservatively managed our patients so far. They get intermittent routine scans, and we're just watching and waiting at the moment. The patient's against any surgery, so we will see what happens. But interesting to see your approach to it.
Yeah, if the pain gets more, she will think about surgery.
Yeah. Any more questions also from the colleagues who someone who put up the hand? Could you please type your question in the Q&A? Otherwise, any more questions from our panel? Okay. So I think we are at the end of our seminar now. I would like to thank you all a lot for coming and being present today, and contributing with such amazing cases, and also what is really interesting, like also unfinished cases or cases where there's not one clear solution. Thank you so much for being with us tonight, and I wish you great Christmas time, happy holidays, and hopefully see you soon again in the new year.
Thank you so much.
Thank
everyone.
you. Merry Christmas.
Bye. Merry Christmas.
Thank you.
Bye-bye. Bye-bye.
Bye.